This lecture will cover Chapter 10, An Introduction to the Principles and Practice of Clinical Chemistry. The clinical chemistry department runs a variety of tests. So depending on the lab, the size of the lab, or the patient population that they serve, or the physicians that they serve, will depend on which tests that they offer within that laboratory department. So it could just be a few simple tests if it's a smaller physician's office lab, or if it's something like a hospital lab, you could have a wider variety of tests. And then if you get into something like a reference lab, then the test may be a little bit more, be more of a variety of tests that are offered. So within chemistry, things are usually offered as a panel or a profile. And so this will be a batch of tests that's included in one test order. So it's not just specific as in you can order a glucose plus all the other tests. It may be that you get the glucose and the electrolytes in one panel. So we're going to talk a little bit about some of those. So your specimens are typically going to be serum or plasma, and with serum or plasma, you're usually going to draw your sample in just a red tube for your serum, or it could be a serum separator tube, which you can see a picture over here to the side. So your red tube here would just be serum, and then your serum separator tube is this gold tube. And some people may still refer to this as a tiger top. So what it has in it is this gel at the bottom. So this gel will create a barrier once it's spun down. Plasma is usually done off of a lithium heparin tube, and that's that green tube. And then your EDTA tube is only used for your hemoglobin A1C. Now, some departments or some labs may include this in chemistry. It's typically included in chemistry, but it could also be included with some of the other departments, like a serology or hematology. It just depends on the workload and where a particular lab would choose to put this test. And some of the other samples that could be done would be urine or other body fluids like spinal fluid. So we talked a little bit about those in the body fluid lesson, where you may order a total protein or glucose off of a body fluid. And so the reference ranges will vary per institute, and it's going to be based on the patient population. So that facility would run some tests and do some studies to determine what is the normal reference range for their patient population in that area. And so I also want to make notes with chemistry, you do have to pay particular attention to the sample quality. So if you look at these samples up top, this first one here where it's kind of a cherry red color, that's hemolyzed. So those red cells, for whatever reason, have ruptured and caused hemolysis. So the hemoglobin that was inside of those red blood cells, for whatever reason, that red blood cell burst open, and that hemoglobin leached out and caused that cherry red color. And then this one here to the side, it is, this tube would be considered icteric. So with an icteric sample, this is usually bilirubin that causes this golden color here. And so depending on the test method that you're using and depending on the particular test, this color here, this bilirubin, can interfere with it, as well as the red cherry color from the hemoglobin, as well as the contents that's inside that red cell, particularly potassium, can cause an increase in potassium when it leaches out of those cells, as well as you can have some other interference due to the color if it's a spectrophotometer type assay where it's checking for a color change. So typically most of your tubes will look like the ones here in the center. where you've got just a pale yellow type color to the serum or plasma. And this glob of stuff here in the center, this is your gel. So here at the bottom where you've got the gel at the bottom, when you spin the tube down, the red cells go to the bottom of the tube, and then you have this gel barrier here in the center, and that gel barrier keeps anything from leaching out of those red blood cells and getting into the plasma and causing any sort of false results. So first we're going to talk about an electrolyte panel. This includes sodium, potassium, chloride, and bicarbonate. Electrolytes are substances that form or exist as ions or charged particles when dissolved in H2O. And they can have a negative charge, anions, or a positive charge, cations. And typically, a physician's not going to order just an electrolyte panel. It's usually included in something else, but some places do still offer these. So electrolytes facilitate many roles within the body, including maintaining fluid volume, osmotic pressure, myocardial cell contractibility, the neuromuscular cell excitability, and an acid-base balance. And so the lungs are a big part of this process, as well as the kidneys. And we learned back in the urinalysis lesson that the kidneys are responsible for excreting anything that you do not need anymore and keeping things that you do need. So if the body is unable to maintain this balance and keep an acceptable concentration, either through keeping what's needed or excreting what it's not needed, then this causes an electrolyte imbalance. And so changes in concentration of sodium, potassium chloride, or bicarbonate is typically accompanied by a change in one or more of the other. So if one is low, then the other may go up or come down depending on its charge. So first we're going to talk about sodium. Sodium is significant in maintaining water distribution, plasma volume, and osmotic pressure. If your sodium level is too low, this is known as hyponatremia, and if it's too high, it is hypernatremia. So some of the sources of error that can happen with running this particular test would be if the sample was run off of a sodium heparin tube instead of a lithium heparin, then that excess sodium that is in that tube would be added to the patient's current sodium level. So it would give it a false increase in that sodium level. So you need to make sure that the sample that you receive is an acceptable sample. Process is important to the regulation of the plasma sodium includes the amount of water that you take in, the amount of water that you excrete. So if you're not drinking enough, that can affect it. If you're not excreting enough, for example, if the kidneys are failing, then that can cause some fluctuations if you're not properly removing the waste. And the regulation of blood volume. So depending on your blood volume in general can also play a role in this. Potassium functions to influence muscular activity of the heart. It also is important in cellular metabolism, in the regulation of protein and glycogen synthesis. And it is a major determinant of the resting membrane potential and is essential for muscular cell excitability. So this is one of those things where if people have muscle cramps, then their physician may recommend them eating a banana because banana is very rich in potassium. So if you have a low potassium, it's hypokalemia. And if you have a high potassium, it is hyperkalemia. Sources of error would be plasma that is from a tube containing potassium. So for an example of this would be if someone drew a potassium EDTA tube, which is the purple tube, And then they realize, oh, I forgot to get a serum tube for chemistry. So they think, okay, well, I'm going to pour some of this potassium EDTA purple lavender tube into this gold top tube, and nobody's going to be wise about it. And so they send that to the lab, and the chemistry department processes that sample, and they get a really critically high potassium level that is not conducive to life. And so when they start calling and trying to investigate what's going on, then somebody may admit to having poured off from a purple top tube. So this is a no-no. You don't ever pour from one tube to the next. Potassium from inside of a red blood cell, or potassium that has leached from a red blood cell if it's sat too long against the plasma, can cause a false increase. So that potassium escapes from the inside of that red cell and then leaches out into the plasma. Potassium that's released from muscular activity, and a good example of this is patients that pump their fist while they're getting their blood drawn or just before. So that potassium releases from that muscular activity and will actually cause a false increase in the potassium level. And I have seen this happen before from a patient that wanted to flex their hands, doing that pumping action because they were trying to show off their muscles and their veins in their arm, and it ended up leading to a critically high potassium level. And the patient, after a restec, ended up being normal. The function of chloride is to determine osmotic pressure, which controls the distribution of water among cells, plasma, and interstitial fluid. It maintains electrical neutrality. It regulates fluid content of the body, and it also works as a buffer during the CO2 exchange in the red blood cell. So this process of exchanging CO2 and oxygen is known as the chloride shift. There's a reciprocal relationship with chloride and bicarbonate. So if you have an increase in one, you will also have a decrease in the other. So if chloride goes up, bicarbonate goes down. Some sources of error would be if the tube was not centrifuged right away or as soon as it clots. Then what can happen is you start having that exchange process taking place, because as soon as blood is exposed to air, then it will actually lose that CO2, and so that exchange of that CO2 removing from that cell can cause a shift in the chloride. And so you want to make sure that those red cells are separated from that serum or plasma as soon as possible. So a bicarbonate measurement is actually a CO2 result. So because 90% of all CO2 in serum is in the form of bicarbonate, then by measuring CO2, you get a very close approximate of what the bicarbonate concentration is in the sample. So assay methods for bicarbonate are actually measuring total CO2. So this is also a useful test and to help with evaluating the acid-base balance and determine if there's any sort of disturbance going on there. So sources of error would be if the sample was exposed to room air, which can cause the bicarbonate or CO2 to leach out, so you would get a false reading. So bicarbonate is measured a lot with blood gas testing. So those tests have to be drawn with an arterial stick, and it's tested right away. It's usually considered like a bedside type test, and because those syringes are made so that there's no contact with air. So an anion gap is not an actual electrolyte, but rather a calculation based off of the electrolytes. So it measures the difference between the anions, which is your chloride and your bicarbonate. So those are your negative charged electrolytes. and then it measures the difference between those and the cations, which is your sodium and potassium, and those are positive charged. And so there are two formulas that are used for that, and those are pictured here. So you have the sodium minus the sum of chloride and bicarbonate, or you have the sodium plus potassium minus the sum of chloride and bicarbonate. And so what you look for with this is to make sure that it's within that range. And if it's within that range, then it's a good indicator that that the patient has a metabolic balance that's good. And so you can feel pretty confident that those results are accurate. However, if they're outside of that range, then it could mean that there's some sort of imbalance happening within that patient. So it's kind of used as like a quality control measure. So most of the machines will do this calculation for you, and it will print this on your results. And you are looking to see if it's outside of that range and determine if it's the patient or if it's something erroneous with the results that you need to look into, like contamination or something. Other electrolytes worth mentioning are calcium and magnesium. And so both of them do have a variety of functions within the body. If your calcium is too low, it is termed hypocalcemia, and if it's too high, it is hypercalcemia. For magnesium, if it is too low, it's hypomagnesemia, and if it's too high, it's hypermagnesemia. Renal function tests or kidney tests include BUN creatinine, BUN creatinine ratio, estimated glomerular filtration rate, uric acid. Urea, nitrogen, uric acid, and creatinine are increased if there is any sort of decreased renal function. Urea is a waste product of metabolism, and it's normally removed from the kidneys. However, if the kidneys are impaired, then it will build up within the blood. So the physician would see this with a BUN or blood urea nitrogen level. If it's too high, this is termed uremia. And if there's a significant increase in the plasma concentration of urea and creatinine, then this is known as azotemia. Creatinine results from the spontaneous formation of creatinine from creatine and creatine phosphate. There are elevated levels of creatine with muscular diseases like muscular dystrophy or with an injury like a trauma. The clearance of creatinine from plasma by the kidneys is measured as an indicator of the glomerular filtration rate. With renal disease, the excretion of creatinine is impaired, and so this is reflected by an increase of this level within the blood. So some of the calculations that are done is the BUN creatinine ratio. And so what this does is help the physician determine if the issue is definitely with the kidneys or if it's some sort of other problem that's happening in the body. The estimated glomerular filtration rate is used to screen for and detect kidney disease early on, but it can also help to monitor the status of the kidneys. And so this can be used to help adjust medications of drugs if there's something that's excreted typically by the kidneys and it could potentially cause problems with the kidneys, then the GFR can be used to see if there's an issue that's starting to happen, and hopefully to catch these sort of things very, very early on. And it can also be used to help evaluate if there is any sort of improvements with therapy. Uric acid is the final breakdown product of purine nucleoside metabolism. And so it's typically seen with three major disease states. And so one of those would be plasma uric acid, which is associated with gout, and so that can usually happen within the joints, usually seen within the toe joints, sometimes the knees, but it can really happen in any joint. And if it can also be increased with renal disease, and also it can be used to help assess renal damage and increase nuclear catabolism from chemotherapy. And so a physician that is monitoring their patient during chemotherapy will sometimes run a uric acid just to see how the patient's responding and if there's any sort of toxicity that's going on from that. A BMP, a basic metabolic panel, it includes the electrolytes as well as the kidney function test, and it also includes a glucose. So glucose is the primary source of energy for most of the cells. Insulin is a hormone that's secreted by the pancreas, and it responds to the glucose by promoting entry of that glucose into the cells, and that's what lowers the blood glucose levels. Glycogenesis is the conversion of glucose for storage, and it's stored as glycogen. But when glycogen is broken down to be used for energy, then that's termed glycolysis. So if a patient has an increase in their blood glucose levels, this is known as hyperglycemia. And if it is decreased, it is hypoglycemia. And this is usually if it falls below 50 milligrams per deciliter. Type 1 diabetes, also known as insulin-dependent diabetes, it results from a cell-mediated autoimmune B-cell destruction, and this usually leads to a total insulin deficiency. If the body ends up having to use the fat, which is lipolysis, to supply energy, then this can be life-threatening to the patient because this produces ketones, and it can cause ketoacidosis to the patients, particularly the type 1 diabetics. Type 2 diabetes, which is non-insulin dependent diabetes, is characterized by an insulin resistance or progressive hypoglycemia. So you see this with people that are usually a little bit older in life. They're well out of adolescence, and they can have several risk factors, or they could have had several risk factors from their childhood. And these individuals sometimes overindulge in the sweets as well. But with type 2 diabetes, it is associated with the development of arteriosclerosis, and it also puts them at a risk of having coronary artery disease or cerebral vascular accident, so strokes and heart attacks. Gestational diabetes is when diabetes first becomes noticed during pregnancy. And so what happens with this is the mother's glucose levels will affect the baby's pancreas, and so the baby will secrete more insulin, which forces that energy to those cells, and then the baby gets a little bit bigger than expected. So when the baby's born, it can lead to complications with delivery and could potentially injure the infant. So usually with this, the newborns will have a low blood sugar at birth because they've produced all of that insulin, and now mom's not taking care of providing that sugar, so the baby's glucose will have a drop due to that insulin production. And so with gestational diabetes, mothers are screened usually around 24 to 28 weeks, and they are given a high dose of glucose that they drink, and then their glucose levels are measured after that dose to see how their body responds to removing that glucose. Some of the terms that are associated with symptoms of diabetes include polyuria, which is excessive urination, hyperglycemia, which is an increased glucose level, glycosuria, which is glucose in the urine, polydipsia, which is excessive thirst, and also blood ketones, which is ketonemia, and urinary ketones, ketonuria. Diagnosing diabetes is done by either by the plasma glucose or a hemoglobin A1C. And so those numbers are listed here for diagnosing diabetes. But you can also determine if the patient is pre-diabetic or they're at risk for developing diabetes. And that would include these levels here where you have a hemoglobin A1C of 5.7 to 6.4, or your blood glucose levels as listed. And so it would be done either fasting or 2 hours after one of those glucose tolerance tests, or just by random glucose that's drawn at any point during the day without fasting. And so if a patient is pre-diabetic or at risk, then the physician may just suggest some dietary changes and lifestyle changes so that the patient doesn't have to go on medications. There are several tests that are used to help with diabetic management. This includes point-of-care blood glucose. And so this is where a patient can monitor their blood glucose level throughout the day. And they do this with a finger stick and a small handheld glucose monitor. A glycosylated hemoglobin A1C. And so this is used to monitor the blood glucose levels over a 3-month period. So what happens is that when hemoglobin A is formed, the glucose binds to the amino group that is part of that hemoglobin A protein. And since red blood cells have a lifespan of about 120 days, then that glucose level at the time that that cell is made stays within that cell. So when a physician wants to monitor their patients, especially the non-compliant patients, they will do a hemoglobin A1C, and they are able to tell a snapshot of how that patient did over a 3-month period versus non-compliant patients who typically like to behave the day or two before they go to their appointment, and therefore their levels look pretty decent that day. However, those hemoglobin A1C levels tend to tell on them. Ketone bodies are monitored, especially if a patient is suspected of having ketoacidosis. And so if the patient is having to use up that stored fat in that adipose tissue, then that would become present. So if the physician expects ketoacidosis, they will run a test on the urine or the blood or both. And microalbumin points to the kidneys starting to be damaged from the diabetes itself. So physicians will use this, especially when they have routine visits with their diabetic patients. They'll get a urine specimen and check for the microalbumin. The CMP includes the BMP test as well as the liver function test. So liver function tests are used to help assess if there's any sort of liver disease that's going on. And so the physician will use those enzymes to kind of figure out exactly where the problem is. So it can help them figure out if it's something like cirrhosis or hepatitis, or if there's gallstones that are hung within the liver. And so depending on which test or increased, it helps the physician figure out exactly where the problem is. The bilirubin is derived from the iron-containing heme portion of hemoglobin, and so this is released when those red cells are broken down and recycled. However, if there's issues with the liver, then it can't process that breakdown product, that bilirubin, and so it can spill over and be present within the blood. Ammonia can cause neurotoxic effects to the body. So if the liver is unable to convert it to urea, then there would be an increase in ammonia. So if a patient is suspected of having liver issues, then the physician will want to keep check on those ammonia levels. A lipid panel will help a physician to evaluate a patient's risk for coronary heart disease and other complications that can arise, like a stroke due to um, the arterial sclerosis, where the plaque hardens within the arteries. And so the physician will use the cholesterol, triglyceride, the HDL, which is your healthy cholesterol, the LDL, which is your lousy cholesterol, and the VLDL to assess how a patient is and what their risks are. For accurate results, patients should be fasting typically about 8 hours before they have their blood drawn. If a patient has had a big breakfast before they come in with bacon and eggs and sausage, then those results can be falsely increased. So you want to make sure that the patient is fasting before blood collection so that they're not put on medications that they don't need. Lipids play an important role in the metabolic process. They act as hormones and hormone precursors. They act as stored energy and metabolic fuels, the structural and functional components of cell membranes, and they also insulate to allow for the conduction of nerve impulses as well as to prevent any sort of heat loss. And so there has been a clear relationship shown between the plasma lipids and lipoproteins causing arteriosclerosis. And so this can lead to coronary artery disease and potentially cause strokes and heart attacks. And so there are several risk factors that are involved that puts a patient at risk for developing any sort of problem due to their cholesterol levels. Cardiovascular disease, again, can have several risk factors that are very similar to the previous. These markers to assess whether a patient has had any sort of heart injury or heart attack include myoglobin, which is the heme protein found in the striated muscles of the skeletal and heart muscles, troponin, which is also found in the thin filaments of the striated cardiac muscles and skeletal muscles, and CKMB, which is also more specific to the heart muscles. A BNP is released in response to ventricle volume expansion and pressure overload, and this is used to diagnose heart failure. And so here we have an image of how the cardiac enzymes respond after a patient has had chest pain or suspected of having a heart attack. So you can see that initially your myoglobin increases pretty rapidly to a detectable level. And so it increases and kind of peaks out at about 6 hours, and then it starts to decline. And by the time it starts to peak, your other enzymes are starting to rise. And then your CKMB kind of peaks out at about 16 to 24 hours, and it starts its steady decline. Whereas your troponin continues to peak, and then it kind of stables out. So at 72 hours, the only enzyme left in the system that you can detect is your troponin. And so if a patient has had some chest pains, maybe they think there's a little anxiety going on, and they go to their physician, call and make an appointment, they get them in a couple of days later, and they tell the physician what their symptoms were, and the physician says, well, I really think we might need to look at this a little bit more detail. So if the physician checks the troponin, then it should still be in the patient's system if they really truly had a heart attack. And it helps the physician kind of get an indicator of what's going on with this patient, and as well as it helps to also rule out, since some of these enzymes can happen with just strenuous exercise and things like that, to help rule out if that troponin stays in that system, then they can kind of narrow it down to a heart attack and not just being some overworked muscles. Your thyroid assays include your TSH, T3, T4. So your TSH responds to a need for the T3 and the T4. So if the body signals that it needs T3, T4, it will send a negative feedback loop to the brain, and that pituitary gland will secrete that TSH, which in turn tells the thyroid to produce more T3, T4. So with hypothyroidism, the body has stopped secreting or decreased secreting that free T4. And when that happens, then that feedback loop is telling that pituitary gland to release more thyroid secreting hormone to tell the thyroid to start making more. However, if for whatever reason the thyroid can't make any more, then it's just going to keep sending out TSH, which is going to make that TSH level go up, but those free T4 hormones are going to stay low. And then the opposite happens with the hyperthyroidism, where you have an abundance of that free T4. So perhaps the thyroid is just producing over and over and over, and it's not stopping. So it sends back that, hey, I've got enough, but the pituitary gland stops sending out the TSH. But since the thyroid's just on hyper mode, that TSH does no good, the fact that it's being cut off, because the thyroid is still producing without being told to produce. A tumor marker is a substance that is present either in a tumor or it is produced by the tumor, or it could be something that is produced by the host in response to the tumor. And so it's often used to differentiate the types of tumor, to tell if it's a tumor versus normal tissue. And it also can be used as a screening type tool, although it's not used as much as it should be. But it can be used as a screening for cancer. And it can also be used to monitor how a patient is responding to therapy, or if the particular cancer has returned. So some examples of tumor markers include the alpha-fetoprotein, which we learned about with the body fluids lesson. And so this can be seen with several cancers, but it also can be seen with a particular type of liver cancer. Beta-HCG is associated with testicular cancer, and this is the hormone that is detected with pregnancy. So finding this hormone in a man would definitely throw up some flags. CA15-3 or CA27.29 is associated with metastatic breast cancer. So this is breast cancer that has spread. CA19-9 is associated with pancreatic cancer. CA125 is associated with ovarian cancer. And PSA is associated with prostate cancer. And the CEA is associated with several cancers. However, it's often used to monitor therapy. So for example, if a patient has lung cancer and they're going through chemotherapy, so in order to see if that patient is responding to that particular chemotherapy, the physician might do a CEA before they start treatment, and then maybe a month after treatment to see if the patient is having a good response. And so this kind of keeps from having to send the patient to get multiple imaging tests done, which can also be very expensive. Therapeutic drug assays are used to monitor the concentration of that particular chemical within the patient's body. And so typically this is monitored to make sure that it reaches a therapeutic dose without actually causing any sort of toxicity to the patient. And so a lot of antibiotics are used for this. Lithium is monitored sometimes this way. And what this monitoring does is it uses the drug's half-life, to determine when the steady state is reached, and it's also can be based on the patient's response. So what will happen is a trough level, which is the lowest concentration, is drawn usually before the medication is ever started. And so in the case of like an IV bag, before they hang it, and then once that drug is started, then usually about an hour after it is given, then the peak level will be drawn. So your peak level should be the highest point, and so this is where it's the highest point but not toxic. And so to reach steady state, that drug will need to be given in intervals so that it reaches that point of being consistent but not being toxic. And so an example of this that you may be more familiar with is if you're running a fever, if you've been sick and you're running a fever, then you usually will keep Tylenol in your system every 4 hours or every 6 hours to prevent that drug from getting too low in your system, which would allow that fever to creep back up. Or with pain meds, if they tell you to keep your pain meds in your system every 4 hours or every 6 hours, then you know that once you get close to your next dose, then you usually can feel that pain coming back because that drug is being processed by the body and excreted as waste. So drugs of abuse, including things like street drugs, alcohol, painkillers, or antidepressants, are usually screened sometimes with a point of care test, like what you see here, where the patient will submit a urine sample and then those strips will test for each individual drug. Or it can be done through a little bit more complex testing through several different chemistry analyzers that you can find in most basic hospital labs. Or it can be some complex type testing, which can include any sort of immunochemistry analyzer, even gas chromatography.